So why did you call 0 in? And your rush, why did you choose rush for your patient? The blood rushed in after you did the dilatation, is it? Okay.
Good morning, everyone. I'll be presenting on behalf of Medicine 5.
Just speak a little louder, Sharon. Yes.
Good morning, everyone. I'm Sharon Kikita from Medicine first year PG. Today, I'll be presenting on behalf of Medicine 5. Presenting Mr. L, a 39-year-old gentleman from Bangalore, presented with history of fever for 1 week, which was low-grade intermittent, with history of vomiting for 2 days, which was non-bilious and non-projectile, with history of yellowish discoloration of the eyes for 2 days, and breathlessness for 1 day. He gives no history of any abdominal pain, clay-colored stools, or melena. He has no other comorbidities, and he's an alcohol consumer for 13 years. When he came to the ED, his vitals were pulse rate of 130, which was regular, with a blood pressure note of 150/80, and his respiratory rate was 44. He was in distress. He has icterus on general examination, but there is no pallor, cyanosis, scrubbing, retinopathy, or hidden edema. And systemic examination, he has bilateral post crepitation scattered over the lung fins, and abdomen, there was tenderness in the right hypochondric region. It was not distended. The rest of the systemic examination was normal. So summarizing, a 39-year-old gentleman with no comorbidities, with a history of alcohol use, has presented with history of fever, jaundice, vomiting, with tenderness in the right hypochondric region, and was in respiratory distress at the time of presentation. So he has presented with these complaints. So our initial differentials that we have considered were cholangitis, acute auricular cystitis, and liver abscess. We have also considered possibility of other acute undifferentiated febrile illnesses presenting with ARDS like scrub typhus, lepto, and enteric fever, and dengue.
So given the history of heavy alcohol use, did you consider that this could be due to alcohol related?
So it was acute onset, so that's why we have not considered.
Okay. What other illnesses present with fever, jaundice, and respiratory distress? And if you look at the causes of AUFI, which present like this, what are the diseases which present with fever, jaundice, and respiratory distress and right hypochondrial tenderness?
Acute hepatitis, cholangitis.
Yeah, other causes of acute undifferentiated febrile illness, which are the clinical illnesses that we see. We're in the fever, we are post-monsoon, right? And we're seeing a lot of epidemic illnesses. What are those diseases which present like this? It's there in your differential diagnosis.
Scrub typhus, dengue, enteric fever.
Leptospirosis, right? Yeah. Okay, so these are proceed.
So initial investigations revealed a HB of 14 with a WBC of 9,400. There was left shift present with toxic changes, and platelet counts were 9,000. He had an elevated creatinine of 1.29 with a urea of 68 with a Bun-creat ratio of 29. He also has acidosis with a bicarb of 10, and LFT shows elevated liver enzymes with elevated alkaline phosphatase and direct hyperbilirubinemia.
So what would you call this LFT pattern?
Cholangitic pattern.
So what is the hallmark and what are your main findings that you're seeing here?
The alkaline phosphatase is much elevated compared to enzymes that is.
Yeah, so what do we call that? Cholestatic?
Cholestatic.
Or cholestatic pattern. Yes, proceed.
And initial ABG has revealed severe type 1 respiratory failure, and hence was intubated and was shifted to ICU. So this was his X-ray at the time of presentation. So we can see that there is bilateral heterogeneous opacities. So it was more in favor of an ARDS picture. Because he was complaining of tenderness on the right abdomen, we have done an ultrasound abdomen and also elevated liver enzymes, which was normal. And the other AUFI workups and all the serologies were also normal. So he was initially started.
So the ultrasound showed no evidence of a cholecystitis, a cholangitis, or a liver abscess.
Yes.
Yes. Okay.
Here the blood culture group Klebsiella species, which is pan-resistant, pan-susceptible. So, but because he was in severe ARDS and there was a documented hypertension during the ICU stay, we have continued him on meropenem. Because of the liver enzymes was persistently high, and in view of high clinical suspicion, we have repeated the ultrasound abdomen after few days. And after few days, ultrasound abdomen has shown multiple conglomerate liquefied collections in the right upper lobe of the liver in the segment 5 and 6, largest measuring 6 into 6 centimeters. So in view of the liquefied collection, we have inserted pigtail catheter and the pus was aspirated and sent for culture, which again grew a pan-susceptible Klebsiella species. So,
any other differential you will think of apart from Klebsiella?
E. coli is other concern. E. coli, Streptococcus can be considered.
Multiple abscesses, I think you also need to consider glandals, right? Burkholderia. That's another thing that can cause a respiratory distress as well. Okay. So keep that in mind. Clinically, of course, culture Klebsiella. Yeah.
So why do you think the initial ultrasound missed the abscess? Because here, you made a diagnosis of liver abscess when the patient presented, did an ultrasound, but you could not see any abscess. And then the follow-up ultrasound showed multiple abscesses in the liver.
So you consider possibility of an evolving abscess. Probably we have done an ultrasound before the formation of an liquefied
so early abscess, which is not liquefied, may be missed on the ultrasound.
So in view of the sensitivity, we have downgraded to ceftriaxone, and in spite of that, he was continuing to have high-grade fevers. We have also done a string test, and RMPA positive string test has come out negative, and RMPA has come out positive, which means it is a hypervirulent Klebsiella. Because it was hypervirulent Klebsiella, which is pan-sensitive, we have continued him on ceftriaxone, and his fevers during the ward stay has come down. But during the ward stay, he is complaining of left thigh tenderness, and on examination, he was found to have a tenderness with warmth over the right thigh, and we have done an ultrasound MSK, which revealed a 2 into 2 centimeter abscess over the right thigh. However, it was not drainable. We have attributed it probably to the Klebsiella, hypervirulent Klebsiella causing abscesses. So I would like to talk about hypervirulent Klebsiella. Now, Klebsiella is a virulent pathogen which is more virulent compared to a classical Klebsiella pneumonia. It was first identified in 1980s in Taiwan when it was presented as pyogenic liver abscess. One distinguishing feature from the classical Klebsiella is that it can cause infections in healthy individuals in spite of the age, and it is mostly community acquired, and it has an ability to metastasize to distant sites. And the hallmark clinical syndrome is an hepatic abscess in the absence of biliary tract disease. So, what are the virulence factors that we say that is hypervirulent Klebsiella and not classical Klebsiella? Is the one is it has a capsule. Even classical Klebsiella species have capsule, but the hypervirulent has a proper trait to produce hypermucous viscosity, which is not seen in classical Klebsiella. And it also has a virulent plasmid, which has RMPA, RMPA2. These are the other virulent factors that are distinguishedly seen in hypervirulent species than in patients with classical Klebsiella. The other virulent factors that can be seen are colibactin and other siderophores also can be seen. So how do they usually present with? So like I said, this is a hypervirulent strain which has an ability to metastasize to different regions. So it can present with a liver abscess, can present with pneumonia, can present with meningitis or endophthalmitis, and can present with a skin superficial infections and also bacteremia. So as you already know that this can the hypervirulent Klebsiella can occur in immunocompetent patients. It can also come in patients who are have immunocompromised, like because of the pure diabetic control, which they will increase the chance of metastasis. How do we test this? One is positive string test, but not all the species of hypervirulent Klebsiella show a positive string test. There are certain hypervirulent Klebsiella which do not have the hypermucoviscous phenotype, and hence they can have a negative string test also. The other one is we do a PCR testing for RMPA and RMPA2 gene. If it is positive, it is highly sensitive and susceptible to say it is a hypervirulent Klebsiella. Now, how do we manage the patients who have come with hypervirulent Klebsiella? One is early initiation of antibiotics. And usually we give the antibiotics for a duration of 2 to 6 weeks. The other thing is source control. So in our patient, because he had a liver abscess and he also had other abscesses into the thigh, pigtail insertion for removal of the abscess, source control is other mode of management for these patients. In case of patients who come with endophthalmitis, in vitreous injections can also be given. So these are the case reports over the past 10 years. There are multiple case reports, but these are the case reports where the patients do not have one patient showing has no prior comorbidities, and the other patient has a comorbidity of diabetes and hypertension, who has presented with liver abscess and on evaluation was found to have a hypervirulent Klebsiella species. This is all pan-susceptible hypervirulent Klebsiella species. So the mode of management was source control and also early initiation of antibiotics based on the culture sensitivity. There was a study published in CMC in 2024, where we are talking about multi-drug resistant hypervirulent Klebsiella. It is shown that now all the species of hypervirulent Klebsiella are also becoming multi-drug resistant. So how do we treat such patients is based on the culture report. So I would like to end my presentation with learning point. One is hypervirulent Klebsiella. Hypervirulent Klebsiella is an hypervirulent hypervirulent Klebsiella is an virulent pathogen which can metastasize to different areas. So during the ward stay or during the time of presentation, thorough clinical examination and history taking during the entire ward stay should be necessary, because in our patient he has initially presented with a pyogenic abscess, but during the ward stay he has complained of a right thigh abscess, and on evaluation was found to have an right thigh pain, and evaluation was found to have an abscess. So every day we have to examine the patients carefully to look for any signs of metastasis.
Thank you, Sharon. Why do you think this gentleman developed a Klebsiella bacteremia with abscess, muscle abscess? What was the risk factor in this particular person?
This patient does not have any risk factors of.
He had a very important risk factor.
Alcoholism.
So why do people who are dependent on alcohol and who have liver problems, why do they develop a Klebsiella bacteremia?
I'm not sure.
So in a person with a liver disease, why do people actually have bacteria which enter from the gut and go into the bloodstream?
Because of the enterohepatic circulation.
Yes, but that's not the reason. Is there some other thing which happens which reduces the defense and allows bacteria to cross the intestinal mucosa and go into the bloodstream? You heard of the phenomenon of translocation of bacteria, which is very high risk. So people, which is the most common Klebsiella infection in an alcohol-dependent patient, alcohol abuse patient? Klebsiella pneumonia. So they can develop a pneumonia, they can develop bacteremias. And here, in this case, had a major abscess. On clinical examination, how will you differentiate between a cholangitis, cholecystitis, and a liver abscess? What clinical signs will you look for?
Cholangitis can present with the Charcot striatum and the Reynolds pentile.
Yes, yes. Cholecystitis, again, Murphy's sign. Where is the tenderness in a liver abscess?
Usually in the right upper quadrant.
Have you heard of the phenomenon of intercostal tenderness? So you press in the intercostal spaces, and earlier, even before the ultrasound, we would needle the abscess because we would make a clinical diagnosis and then put in a needle. So you have to look for intercostal tenderness. It is really surprising here that the patient had a liver abscess but was missed on the ultrasound. That is very seldom the case. So here in the setting, I think it would have been more prudent to actually go down and with the radiologist and actually screen the liver carefully, because obviously the ultrasound missed the liver abscess in the early phase. Any other comments, sir? Would you like to make any other comments?
I think, like you said, Anand, we used to see patients with liver abscess diagnosed based on intercostal tenderness and a raised right dome of the diaphragm on the chest X-ray. You've come a long way. You have ultrasound. But it is interesting to know that in early stages of liver abscess, you can miss it even on an ultrasound. I think the important thing is then to repeat ultrasound like you did after a couple of days to find that there's a problem. The other point I want to make is when the patient has prominent respiratory tract infection, alcoholic, you need to think about aspiration. Okay? Aspiration pneumonitis. Not sure whether Klebsiella can be a causative organism for aspiration pneumonia. Anand, any ideas on that? Like you said, Klebsiella probably entered from the gut and set up a septicemia here. And very often, patients with chronic alcoholic liver disease have another reason for developing a septicemia. The blood from the intestinal tract bypasses the liver and goes into the systemic circulation of the collapse. Okay, so that's the other reason why they readily develop a septicemia. Liver filter does not work. Okay, so the number of reasons why they are prone to septicemia. But do you have any ideas about Klebsiella causing aspiration pneumonia? Could it have started that way and then led to septicemia that involved the liver? Or you think it's a gut origin?
So we know the classical Klebsiella pneumonias, they affect the upper lobe and they produce the bulging fissure sign. Quite severe pneumonias, and they are very easily, X-rays pick them up. Here in your case, there was no evidence of a pneumonitis, right, on the chest film. No, sir, I don't know about aspiration pneumonia, but here the patient was obviously bacteremic and had probably an adult respiratory distress syndrome, had seeding to other sites, hematogenous spread with involvement of the muscle. So it was obviously a very virulent Klebsiella pneumonia, and part of the bacteremia. Where was the source? Was it from the gut, from the respiratory tract? It's not very clear.
And the other important question, I think it's a research question, would be where the hypervirulent Klebsiella acquired these plasmids that contribute to the increased virulence. I mean, if you had not told me about the organism, the first thing I would have thought of is actually Burkholderia. Okay, multiple abscesses, including in the thigh, liver, lung. Okay, so that would have been an important differential diagnosis on clinical grounds. Do you have any idea where the Klebsiella acquired this virulence plasmid from? Which other organism? Is there anything you've read up about? If you haven't, I think it may be worth looking. All right.
These virulence factors, I have not seen any other organisms. They said it is specific to hypervirulent Klebsiella.
Yeah, I can't hear you.
So these the mucoviscosity and RMPA genes, these are specific for hypervirulent Klebsiella. Is not seen in any other species.
So are they acquired plasmid? Are they transferred through plasmids? Is Dr. Sheshadri's question. And if so, where do they come from? And where is the first cases of hypervirulent Klebsiella reported?
It was reported in Taiwan in 1980.
Taiwan.
Where they presented with pyogenic abscess with endophthalmitis.
Okay, abscesses. And has it been spread across to different places?
It is most commonly seen in South Asian population and rarely in the European population, sir. but there are multiple studies showing multiple infections involving, liver abscess and pneumonia and bacteremia caused by hypervirulent species.
And you're saying that we are having cases here also in Vellore of hyper. And when were the first cases reported in Vellore?
I looked that up, sir.
But tell us about that string test. You mentioned the string test. Can you explain that?
So in a string test, we grow the hypervirulent Klebsiella, in Klebsiella species in an agar plate, and using the string rod, we'll see if there is an viscous string which is measuring more than 5 mm, which indicates it's a positive string test. If it is less than 5 mm, it is negative. More than 5 mm indicates a positive string.
But what is the principle of the string test?
What exactly did you, Anand? The string test?
I want to find out.
Sir?
Can you explain the string test?
So in the agar plate, we grow Klebsiella species, and these if there is a hypervirulent Klebsiella species, they will have an capsid which produces a hypermucosity, which when we pull it with a string, when we pull it with a rod, will produce a viscous string which is more than 5 mm.
So it's an indication of the virulence, the hyperviscosity,
yes.
And the bacteria stick together and produce a long
string measuring more than 5 mm. If it is less than 5 mm, or if you are not able to produce it, which means it does not have the hypermucosity.
So it's a simple test to identify hypervirulent Klebsiella
but it is not very specific, as there are some phenotypes which do not have the hypermucoviscosity.
Any other comments on Sharon's presentation? Thank you very much. So any comments on the overall presentation, sir?
Oh, it was very nice. I learned a number of things. I think I'm actually joined the meeting to learn. Okay. And I'm glad I attended and learned a few things from our younger colleagues. And I'm very happy that the clinical skills of the postgraduate students in CMC continues to be extremely good. We are picking up things on routine physical examination that can easily be missed, like the coarctation in a pregnant woman. Okay, I think unless you check the load in the pulse, you would have missed the diagnosis. The patient might have come in labor and have had problems. And very interesting patient with this hypervirulent Klebsiella infection. That's a very important thing. But organisms tend to talk to each other in nature, and then they keep exchanging genetic information through plasmids. And so it might be interesting to go back and find out where this hypervirulent factors came into Klebsiella, or whether it was de novo evolution in Klebsiella. That might be interesting to look at. And the patient with the potassium dichromate poisoning was again an eye opener. And I think a very careful history is what led to the diagnosis, right? If you hadn't thought about it and probed a little deeper, you would have missed the diagnosis. Thank you very much for a very interesting morning. Thank you.
Yeah, I think that the medicine clinical meeting was at the high point of the week, where we used to see all these interesting cases. And I remember when Dr. Pulamud was there, he would insist that the cases be brought to the clinical meeting. So we would actually have to present with the patient and demonstrate signs. And they were all very interesting cases. I remember a patient presented by Dr. Sarojini Pancharatnam, who was in the low-cost effective care unit. This is a young boy who presented with seizures. And he said that on examination, there was a subcutaneous swelling. And so she asked, what is the diagnosis? You see the diagnosis? So she pulled out a jar where they had biopsied it, and it was actually a cysticercal cyst. And this diagnosis of a neurocysticercosis was just done by the clinical examination. So it's a very fascinating clinical meetings when you have the cases. And in the earlier period, we had the pediatrics actually with medicine. So we had a combined clinical meeting. And of course, the highest point of the clinical meetings over the years were the CPCs and huge amounts of learning. And I think that's something that really the department should go back to, because it's where we learn always from when the person had a, the very difficult case and how senior clinicians approach that. So I think today, the first case of the radiofemoral delay, and it was a sort of story which we heard about, that Dr. Shankar Krishnaswamy, former head of cardiology, was failed in his DM exam because he missed the radiofemoral delay. And such is the importance of a proper physical examination. We must appreciate Osborne's team for picking up that. And Dr. Sheshadri highlighted the importance of picking up the ejection click as a clue to the diagnosis of a bicuspid aortic valve. The second case, again, the history and the evidence of crepitus over the neck as features of a pneumomediastinum. And in the third case, I think Sharon highlighted the importance of clinical examination, the diagnosis of a liver abscess, and of the evidence of a muscle abscess in a patient with sepsis. So thank you all. And I think all the presentations were good. And I think all of you should get an award. But since I have to give one award, I'm going to give it to Osborne. Thank you very much, sir, for joining us today.
Yeah. Thanks a lot. I learned a lot. Thank you.